You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for June 1st, 2018. This week, I'm talking surgical left atrial appendage occlusion, renal denervation for hypertension, a relook at the ORBITA trial, FAME2 5-year results, and hypertension guidelines. So first up is that another large observational study on surgical left atrial appendage occlusion has been published in a major medical journal. This was from Mayo Clinic authors, and it was an administrative claims study published in JAMA. It was about 4,200 patients who had surgical left atrial appendage occlusion at the time of heart surgery, compared with about 4,200 patients who did not have the appendage closed, form the control arm. The authors used propensity matching in an attempt to minimize confounding of the non-randomized groups. And these results are similar to the last one of these studies, which was also published in JAMA, and that is that left atrial appendage occlusion associated with a reduced risk of stroke and a lower mortality compared to the control arm. And in a secondary analysis, the authors also found that left atrial appendage occlusion associated with more atrial fibrillation and more hospital admissions in follow-up. The authors also stratified outcomes of appendage occlusion based on the presence of AFib, and this analysis showed that patients who had AFib before the surgery and then had appendage occlusion had less stroke and death than patients without a history of AF, which makes sense, but the p-value for interaction did not even get close to significance there at 0.29. So the credit here, I have to give some credit to the editors and peer reviewers, because at least the conclusion of this paper added the sentence, quote, further research, including from randomized clinical trials, is needed to more definitively determine the role of surgical left atrial appendage occlusion. Of course, that statement in the paper did not stop one of the senior authors from making bold statements in a news story, which went like this, quote, until we have results from the randomized trial, I think our data from this study could be used to guide practice. And also, quote, I would say our results support the closure of left atrial appendage occlusion in patients with existing AF, but they do not support this practice in the absence of AF. And I would say, no, I disagree. These sorts of observational studies have fatal flaws. Despite propensity matching and attempts to test for falsification, which was done, patients who get surgical left atrial appendage occlusion are almost certainly healthier than those who do not. And it's probably these other factors that lead to the association with better outcomes. Look at the data in this paper. Surgical left atrial appendage occlusion may reduce stroke. Okay, fine. But the hazard ratio for mortality reduction is lower than that for stroke, and that's not plausible. The only way surgical left atrial appendage occlusion can lower mortality is to lower stroke, and that mortality is lower suggests that the patients are healthier. Now, I led with this story, and I emphasize it because observational trials might be worse than no trials. When there are no trials, at least we know we don't know something. But in the presence of observational trials, key opinion leaders will cite them, and many will be afraid to challenge key opinion leaders. What's more, another problem of observational studies is the cost of doing the RCTs to overcome the misperceptions from the spurious observations. In the case of left atrial appendage occlusion, indeed there is an ongoing RCT. It's called the Left Atrial Appendage Occlusion Study, or LAOS, and I predict it will reverse the practice of surgical left atrial appendage occlusion. Next up is renal denervation. Now, 2 trials presented at the EuroPCR meeting and published in Lancet hint at a rebirth of interest in renal denervation. Now, recall that the initial excitement from unblinded trials was then diminished when a sham-controlled Simplicity 3 trial showed no effect. Well, now the interventional cardiology community has different devices to do the renal denervation, and they've chosen patients a little differently for the procedure. The first of the 2 trials, the Spiral Hypertension on Medicine trial, studied the use of the Medtronic Simplicity Spiral Multi-Electrode Ablation Catheter. So different than the first one in that this had multiple electrodes. The old one had just a single tip. Also, this multi-electrode catheter was used more distally in the renal artery, so a different technique than in Simplicity 3 trial. Now, in the spiral hypertension on medicine trial, they had 25 centers, 80 patients. All patients had to have uncontrolled hypertension on 3 meds, and investigators closely monitored for drug adherence. And they found both office and 24-hour systolic and diastolic blood pressure dropped at 6 months. The systolic blood pressure in the office went from about -2 in the sham arm to -9 in the treatment arm. The most important finding from this study may have been in the appendix, though. The medication adherence in this carefully done trial was only 60% in both groups. That has implications. And crucially, though, this was an exploratory proof-of-concept trial without powered endpoints. And because of the uncertainty of renal denervation, investigators and FDA decided on 2 smaller proof-of-concept studies to gather information on feasibility while exposing as few as possible patients to the procedure because they weren't certain. The second published renal denervation trial presented at EuroPCR was called the Radiant Solo Hypertension Trial. This trial used a novel ultrasound-based ablation device which allowed making more proximal lesions, which only took seconds, actually. The trial enrolled about 146 patients with hypertension who were not taking medicines after a washout period. And it was sham-controlled, and the primary endpoint, which was the mean change in ambulatory blood pressure, was reduced by about -8.5 versus 2.2 in the sham group. Now, the follow-up of this study is just 2 months, and the investigators plan longer follow-up. Importantly, neither of these trials have any major adverse events from the procedure. So some summary comments on the renal denervation is that this data is not surprising. I was surprised at the original trials of renal denervation. How can they just whip a catheter in there and just willy-nilly burn and expect physiologic changes? I mean, how did they really know what was being affected or ablated? In the EP lab, we don't ablate like that. We ablate and then measure the ablation's effect. For instance, did the ablation eliminate the electrogram? Did it suppress conduction across the line of block? Did the ablation eliminate inducible arrhythmia? We have markers for success. The renal denervation trial used catheters that seem to do ablation in a more focused way. It's still hard to know, though, what the physiologic effect it has at that moment in the renal arteries. It's also important to point out that the powered trial had only 2 months follow-up, and the RF trial are essentially phase 2 trials. So I don't think we're ready for prime time to do renal denervation yet, but there's more to learn. But now, at least, there is a signal to look at this procedure in longer and larger trials. It should also be remembered that here, many are excited about a 6 to 9 millimeter drop in blood pressure, but also remember that in the Black Barbershop study, an intervention using pharmacist visits in the community using generic medicines resulted in a nearly 22 millimeter drop in blood pressure. Third topic today is another analysis from ORBITA. Now, Dr. Rasha Alami presented a secondary analysis of the ORBITA trial at the EuroPCR meeting, and Circulation published the paper. In the original ORBITA trial, the investigators expected PCI to exert a very large effect on angina. And given that, they figured that after that trial, they would be able to parse out a particular cut point from the IFR and FFR data. In other words, that the degree of ischemia relief would predict the degree of angina relief. Well, you know how the main ORBITA results came out. They were surprised. There wasn't a statistically significant effect on angina or exercise time. This study, however, did show that IFR and FFR correlated well with the degree of ischemia reduction as measured by stress echo. The tighter the lesion physiologically, the more the improvement on stress echo. But, and the key point here is that the IFR and FFR had no prediction of angina relief. A relief of a tighter lesion did not change angina symptoms. So that's quite surprising. Now, the second part of this Circulation paper was a post hoc analysis that was not a pre-specified analysis, and it involved dichotomizing angina into 2 categories: freedom from angina or not free from angina. And here, when you use this category, PCI did result in a statistically significantly greater number of patients with freedom from angina. So my comments on this are that these results hardly change the interpretation of ORBITA. First, we knew from the original trial that PCI relieves ischemia, but it had little to no effect on angina. This substudy's findings on stress echo confirms that. PCI improves ischemia, but had little effect on angina. The second comment is that the positive score on angina in this study was not pre-specified, and angina is a continuous variable, and dichotomizing it is going to be less statistically robust, especially when the primary analysis of the continuous variable was negative. And if PCI does relieve angina and IFR and FFR predict stenosis, how in the world does relief of tighter lesions not improve angina symptoms? And for those that argue that we should not dichotomize p-values, for instance, we shouldn't say that p of 0.05 is positive and a p of 0.06 is negative, I still argue that if PCI was an angina drug, and these were the results, and the drug had the same complications of this invasive procedure, there's no way that drug would be improved. You're looking at most a 20-second improvement in exercise time. That's not much for a lifetime with having a metal cage in your artery and having to take dual antiplatelet therapy for an unknown period of time. Fourth topic is on the FAME2 5-year results. Now, the New England Journal of Medicine published the 5-year results of FAME2 trial. Recall that the original FAME2 trial randomized about 1,200 patients with significant lesions as defined by an FFR less than 0.8. And these patients were randomized to either PCI plus meds or meds alone. And then patients with significant lesions but had an IFR greater than 0.8 were entered into a registry. The primary endpoint was a composite of death, MI, and urgent revascularizations, and the 3-year results were positive, but the primary endpoint, as everybody knows, was driven by urgent revascularizations, which of course is the softer endpoint and one that is subject to the bias and lack of blinding. For instance, if you say, sir, you have a bad blockage, but we didn't stent it, what do you think happens the next time that guy gets a PVC or any symptom above the belt? He's going to go in and get urgent revascularization. So the 5-year results of FAME, which came out recently, looked a bit better. Yes, urgent revascularization still favored PCI, of course, and death was still no different in either group, but now the MI signal was slightly lower in the PCI groups. The curve started to separate after 3 years. MI rates in the PCI arm were 8.1% versus 12% in the medical arm, and the hazard ratio was 0.66, but the upper limit of the confidence interval just touched 1.00, so technically not significant. Angina relief was better in the PCI group initially, but it had equalized in the medical arm by 5 years. So the important points here are to point out the limitations of the paper, which the authors did lay out in the second to last paragraph in the manuscript. For instance, FAME2 was stopped prematurely, and of course everybody knows early termination tends to exaggerate treatment effects. Also, the sponsor decided to close the trial after completion of the 3-year follow-up. Now, the academic steering committee invited all 28 centers to participate, but only 19 centers participated in this results, so there's missing data. And these two factors lead to lower than predicted number of events, which limits its statistical precision. And as I mentioned, FAME2 is unblinded, and of course that leads to differences in clinical management and affects the urgent revascularization part of the primary endpoint. Now, I would also add, and I discovered this through my communications on social media, that there's a really concerning paper originally published in Circulation in November 2017, which I'll link in the podcast, and it's from the FAME2 authors. This paper, a substudy of FAME2, looked at angiography versus hemodynamics to predict the natural history of the coronary lesions. And in this paper, the FAME2 authors found that the FFR is a more important determinant of the natural history of a coronary lesion than the anatomy. The problem was that in the post-publication review on social media mostly, and it was led by Dr. Venk Murphy from the University of Michigan, he found up to 100 errors in the paper. And the authors have issued a correction of these recently, but they were missed by peer reviewers and editors and was actually in publication for 6 months before this was picked up. But even more importantly, Professor Daryl Francis from the UK and others have been tweeting about the possibility that authors in the circulation paper actually imputed many cases of a 0.5 FFR based on the visual appearance of the lesions. And they used the scatter plot from the paper from the figure 1 that was published in the circulation paper, and they did a binomial statistical analysis and found out that it was nearly impossible that these numbers weren't imputed. So given the limitations of the paper in the New England Journal, any errors from the circulation paper, it's hard for anybody to really know about the role of FFR. I think there's a great deal of uncertainty, and I think we're going to have to learn more about the specifics of these findings on FFR. The final topic today is about hypertension guidelines, and I wanted to point you to an excellent recap of the controversy surrounding these new guidelines. Sue Hughes does a super job of describing the points of contention in the guidelines, and these include the target level of blood pressure, the reliance on sprint data, the use of the cardiovascular risk threshold, and the lack of carve-out for the elderly. Now, while many cardiology groups endorse the guidelines, the Family Practice Association and American College of Physicians do not. I learned a lot from Sue's report. My use of the new guidelines in my clinic is to focus patients more on getting ambulatory numbers, and it's perhaps pushed me more on getting to a lower number than previously, especially with the use of lifestyle measures. That said, the notion of giving many, many more people a disease label bothers me. The family practice group points out that another name for pre-disease states is actually healthy, and that concept rings true for me. While I don't advocate under-treatment of hypertension, I also think we should be careful with labeling healthy people as having a disease. So that's it for this week in cardiology. I'm grateful that you listened. If you have comments, please feel free to leave them in the comments section. I look forward to hearing from you. See you next week. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.